excited because this might be the one and only time I get to share the stage with my partner, my mentor and friend. So it's going to be great. Okay, so we have a quick disclaimer, right? All the cases that we're going to present here have been treated in our practice by us. All the pictures are originals. They have not been modified in any way, and we don't receive any financial compensation for the presentation of the treatment of our patients. And like Dr. Savidanes mentioned, we're going to talk about the class 2 correction and thinking outside of the box, different ways that we do this. Now, we're going to bring to you guys this patient of ours. His name is Louis. Louis came to our clinic for an evaluation. He actually owns and runs a kitchen appliance repair company. He saved a lot of money to go and take care of his oral health because he has a lot of anxiety. And that dentist that he went to was actually my sister-in-law. She identified that he could benefit from orthodontic treatment, so he sent him over to us. As you can see, he's got multiple missing teeth, many restorations, retained roots, and dentally, you can see he has a class 2 malocclusion, deep bite, a mild upper crowding, some lower spacing, and convex profile. He does have a nice chin, as we can see here in the Ceph tracing as well. Class 2 skeletal, upright upper incisors. And now, we do have his diagnosis. And now let's talk about general treatment alternatives for class 2 malocclusions, okay? When the patient is young enough, you can do some growth modification, okay, where we can use different appliances like Maras and Herbst. When there's no growth, and usually in adults, and there you have a more significant skeletal discrepancy, and you can offer an orthognathic surgery option of mandibular advancement. And where you have cases that you can actually do some camouflage and accept the skeletal discrepancy and get to a class 1 dental occlusion. You can do this with or without extractions. Let's look at some examples for growth modification. This patient, as you can see, convex profile, class 2, deep bite. We decided to use a Mara appliance. So you can, as I mentioned, you could use other appliances like a Herbst. Okay? And it's looking pretty good. It's a progress picture. And this is how he finished. It's a class 1 dental occlusion. It's a good result. You can see a superimposition where you can see all the growth that he experienced throughout the entire treatment, especially mandibular growth. Now here, this is his initial picture. And one thing that I learned from Dr. Hernández, he likes to do BTOs, or predictions of growth, or even surgical cases. And this is a prediction that we prepared to see how he would look if he grew right. And this is how he actually finished. Okay? It's a great case. Now, when we have a more significant skeletal discrepancy, like I said, in an adult patient who's willing to pursue surgery, you can do an orthodontic surgery, mandibular advancement. It's a before and after picture in Ceph. Now, there are cases in between where we can decide to camouflage the skeletal discrepancy. In this particular case, this is class 2, upper and lower spacing. It's acute nasolabial angle, protrusive lips. So we decided to have premolar extractions. And this is the resulting correction. Okay? Again, another superimposition where we can appreciate how much the uprighting of our upper and lower incisors we achieved, and also we can see the growth that she had, which definitely helped us achieve such a great result. Now, getting back to the title of our presentation, we want to bring you some examples of cases that were treated with less conventional approaches. Okay? We have all had patients that come in and we explain to them, this is what you have, these are our options, and then nothing is an option. Anything but extractions, anything but surgery. So we have to step out of our comfort zone, okay, and think about more options. Even when the path starts to get a bit narrow, the end seems to be dark, we must have a small window of opportunity to make a difference.
And here we have Elizabeth. She came with this first-time class 2 molar and cuspid. She had a 9 millimeters overjet and some upper and lower crowding. When you see the cephalometric x-ray, she has an AMB of 8. Upper and lower incisors were proclined, 110 and 103. And then she said, well, this is really a surgical case. There is no way. We can either extract upper and lower fours, maintaining the overjet and do a mandibular advancement, or we can do upper fours and lower fives and achieve a class 1 malocclusion, camouflaging the skeletal discrepancy. However, she said, well, I would like for you to treat me non-surgical and non-extraction. She was an adult. She was almost 50 years old. So we attempted to retract upper and lower incisors with mini plates. As a matter of fact, I started with mini pins, but there was no way that I could achieve this result with the mini pin because there was so much retraction. So here we can see a progress where we have midlines coincident, class 1 molar and cuspid, and this is the final result. Midlines on, she's class 1, both sides. Upper and lower incisors are more retroclined. Upper incisor is 103, lower incisor is 98. So it's pretty ideal for her skeletal discrepancy. She's still a class 2 skeleton. She has an AMB of 7. And you see here the superimposition, how much retraction you achieve by distalizing the molars and the whole upper segment with the mini plates. However, how stable is this? Well, she came 13 years after, and she's holding up pretty good. She's class 1, both sides. When we decided not to extract on her was because really, she had multiple restorations. And I wasn't sure, with this kind of mouth, what about if I extract 4 or 5s, and then down the road she loses another tooth because they were pretty broken, all of them. So I feel pretty comfortable with this treatment, and she's holding up pretty good.
Okay, so now back to our friend Louis. You remember Louis, right? Okay, so he's obviously not a candidate for growth modification. He's an adult. Surgery, well, the skeletal discrepancy is not really severe enough to warrant a surgery. And even if it was, I did mention he owned his business, right? His own kitchen appliances repair company. But he's the only sole employee of the company. So medical insurance in Puerto Rico, I guess it might be the same in the States, you have to have at least 2 employees to get like a group coverage that would then cover for surgery. So even if it was severe enough, then he wouldn't be able to cover it, or medical insurance wouldn't cover it. And then extractions, well, mild crowding, lower spacing, or distalizing is not proclined enough, so it was not really another option. So then what? What are we going to do? So this is where we want to bring you guys in, this gray area. Okay, we want you to be able to provide options to your patients. And there are some tissue modification procedures that can be done to help achieve the orthodontic movements that we want. There are many of these procedures, and we're going to focus on decortications with bone grafting, or like Dr. Hernández likes to call them, the pressure site decortication procedure. So he comes in, and we put braces on. Okay, we level and align. We use an 018 slot in our practice. Okay, So we level a line and get to 1622 stainless steel wire, which would be our working wires. This is how it's looking on the 1622, okay? Everything's lined up, but he's still class 2. So this is the point where we reach and refer him to the periodontist, or oral surgeon, in this case was the periodontist, so that she could do the decortication and the bone grafting. He gets there, and she takes a pre-op cone beam where we can see that there's barely enough buccal bone on those lower incisors, which we need to protract to get that class 2 correction. So the day came, and then I received a phone call from Dr. Herrero. He says, Danny, we're going to have to postpone surgery. I was like, what? What happened? Louis fainted. So I cannot do this today. I was like, oh, wow. Yeah, he was pretty anxious. He later told me, like, I don't want to go back there. I was like, no, Louis, you have to go. You have to go. So he finally built up the courage to go to Dr. Herrero's office and get the procedure done. And she opens a flap. These pictures are courtesy of hers. She does the corticotomies, places the graft, and I told her, please place a lot of bone, like a lot of bone. And even when you see it's a lot, just put more. So she did, and sutured up, took a post-op cone beam where we can see the graft that was placed. 1 week later, patient comes back in, then we start to change the lower wires. This is how he's looking. There's plenty of time for him to recover. So you see those funny bends that we have in the lower wire? This is where we are going to show you now how to prepare these wires, okay? And we're going to see him every week for the next 4 to 5 months. Okay? So the first thing that we do is we bend some opening loops distal to the lower lateral incisors. Okay? We're going to have a mild step down or large, depends on the need, right? The upper body of the patient. And we're also going to add about 20 degrees of labial root torque. So you can see here that step down and the 20 degrees of the labial root torque. Okay? I wanted to bring you guys this picture so you can see how much you go above the handle of the plier, right above it, tangent to it, then you get those 20 degrees. Just a quick way you can check that chair side. Then afterwards, we bend some omega stops or omega loops mesial to the lower sixes for the anterior protraction. Okay? So that wire, when you look at it from the top, it's going to be about 2 millimeters in front of the brackets. Okay? So that wire is going to pull the teeth forward. The important thing about that labial root torque is that if we didn't put any torque, the teeth would procline, okay? Pure proclination. And that labial root torque helps us achieve a more bodily movement. So there might be some initial proclination that we see, but as we go through the wires, we're going to increase that torque and we're going to get more bodily movement in the end. So we first tie up the buccal segments and then the anterior incisors, okay? Now this is the wire sequence that we use. Keep in mind that we use an 018 slot, okay? So we sent him for the decortication with a 1622 stainless steel, but then we have such an active wire, we're gonna start with a 1622 TMA, then 1725 TMA, and that could be a week later or 2 weeks later. It depends on how much correction you achieved with that first wire. And then step up to a 1725 stainless steel. So the idea is that we protract the incisors first, and then canines, premolars, and molars. So the class 2 elastics are going to be very important during this stage. So these are his progress pictures. We have not finished this treatment yet, but I wanted to bring you this case because we have recently started using more and more the cone beams to be able to document and bring you guys some pretty good information and see what we have. So these are his current buccal segments right now. You started with this relationship right here, and this is where we're at. From class 2 to class 1. Okay? And this is a superimposition, another superimposition. So as you see, we love superimpositions because you can actually see what's going on, if you do it right, of that movement that we've had. And we're going to focus on those lower incisors. You can see it's a little bit of proclination, but it's more a bodily movement. And then we took a progress cone beam where you can see the current position of those incisors and how much bone there is still buccal to the incisors. I love how she puts so much bone in there. This is about 5 months after the graft was placed.
Okay, our second case is Natalia. When she came to our office, she was treated before with upper premolar, first premolar extractions, non-extraction in the lower arch, and she came with this amount of lower crowding and retrocline lower incisors. She still had the wisdom teeth present, and as you can see, this excessive overjet. So she was a class 2 with a AMB of 6. Maxillary and mandibular incisors were retrocline. Lower incisors were 78 to mandibular plane, and the upper incisors were 99 to mandibular plane, to SN plane. So she rejected any kind of surgical procedure, and her profile was, it wasn't that severe to do a mandibular advancement, and she wanted to have extractions done, and we had to be careful about proclining those incisors without any kind of decortication procedure because I was concerned about that thin bone in the B point. So I did a VTO about how she will look if I move those incisors forward and procline both of them. This is my goal. This was my goal. We started by expanding the upper arch by decortication also. We expanded the upper arch to improve her smile. And then we did the lower decortication, and this is her profile at the end. Midlines are on, a good buccal segment. She is a full step class 2 molar because she was missing 2 upper incisors, and class 1 cuspid. Good root parallelism. Upper incisors now are 98. They were 99 before, and lower incisors 89 degrees. If we compare before and after, we reduced her overjet. Overjet was completely corrected, and her profile looked like she had some kind of surgical mandibular advancement. And all we did was decortication and improve the inclination of the lower incisors. If we compare my VTO with the way she looked at the end, she had a good improvement in her profile. And when we superimpose, this is the amount of proclination of the lower incisors she experienced. As you can see, the lower incisors would be out of the bone in the initial B point that we have in the black tracing. She also had an improvement in the mentolabial sulcus, which is fuller than before. And this is what really happened there. Those lower incisors came forward while we were protecting them with new bone generated there. And you can see here a close-up of the cephalometric symphysis area. So we improved 34% of bone on B point with this procedure. So how stable is this? Well, she came 2 years and she was pretty stable. Her profile looks good. Her occlusion is very nice, and she was pretty stable 2 years after treatment. Good root parallelism and good changes. Anyway, they stayed basically the same. When we see the superimposition, finishing and retention, teeth stay pretty much the same, even though the lower incisors are more uprighted than before. What about stability? How stable are those results? Well, we published a couple of cases, one in 2008 and one in 2009, about this kind of procedures. The first one, when I published this case, the class 2 DIF2 non-extraction treatment, she was 7 years on retention, as well as the other one, the corticotomy-assisted expansion. He was 7 years on retention when I submitted this paper. Right now, I have his records 14 years after, and he's holding up pretty good. This is another example of an adult patient that came to our office, and his chief complaint was that it was hard for him to maintain a good oral hygiene in the lower incisor region. The easy way out here was to extract that lateral incisor that was lingual. However, by doing this, we would be creating a Bolton discrepancy, a severe Bolton discrepancy, and an increased overjet, which was increased already. So we decodicated. We brought those incisors forward this amount. This guy was 60 years old. We brought those incisors forward, and we opened space for the 7 millimeter lateral incisor that was blocked before. And this is a close-up of the lower part of the cephalometric X-ray. You can see here how much bone he has now in the B-point area, which this is an increase of 22% in the B-point region. This case, this is Alanis. Her mother is a dental assistant. As a matter of fact, she's a dental assistant of the periodontist that I work with. I presented mandibular advancement option, but her family rejected surgery easily. Her occlusion was class 2 molar and cuspid, and she had some crowding and excessive overjet. She had wisdom teeth are present. She had an AMB of 5. Maxillary incisor was 105, mandibular incisor was 92 degrees. So really, I like the angulation of those incisors to the face. I wanted to maintain them, but she had crowding, and she was class 2 in both buccal segments. So again, they were looking for the corrugation procedure in the lower part of the symphysis to move those incisors forward. And this was my VTO, how she was going to look if we move them forward. You can see the mentolabial sulcus was fuller in my prediction. Here we can see some generalized spaces as we move her incisors forward with good root parallelism. And that's very important that you maintain good root parallelism, because by moving them forward, you can touch one root the other. You don't want to have any complication during this procedure. This is how she's looking now. She's in the middle of treatment, and we haven't finished her. I brought her because he placed a lot of bone graft for her, and you can see here how bone was improved here, and she in the symphysis region, in the B point region. You can see in this phallometric X-ray how much bone she had there, and how much forward we moved those incisors after the procedure, which was were significant. So, question is, can we achieve ideal results in all cases? Well, maybe not in all cases. However, as now that we have more options in our toolbox, our conclusions are the inclusion of pressure site decodification procedures with bone graft in our treatment protocols allowed us to modify the dental housing in which teeth are confined. Considering all spectrum of treatment options available, we should be able to maintain the same functional and aesthetic standards. high standards when treating difficult malocclusions. By using pressure side decortication procedure, we have experienced better long-term stability. Remember that as scientists, we should continue in search for the truth, and someday we'll be on top of the pyramid. Thank you for your attention.
Thank you so very much for this intriguing presentation. We have questions for Dr. Hernández Orsini and Dr.
Díaz Rubayo. Díaz Rubayo. Díaz.
Díaz Rubayo. Sorry for that. So the topic of decortication always raises the concern of the bone degeneration, and in some of the superimpositions, we do see, due to the design, that there is a very thin bone corticoplace. Have you had issues with dehiscences or fenestrations in these patients after the therapy for correction of class 2?
Not one case. And I have treated more than 150 cases with these procedures, either for expansion or for proclination, and I haven't seen one. In one of my cases, the expansion that we published in 2009, that guy, when the periodontist opened a flap, those molars were out of bone almost completely. That doesn't mean they didn't have bone, but the bone was very thin. And right now, he's following up with the specialist, the periodontist, and no pockets, and everything is perfectly healthy. It is operator sensitive. So you have to be careful with who is doing the procedure for you.
And have you worked with decortication together with mucografts, or it's just the decortication?
No. If we need to do a graft, sometimes he does the graft before, if it is a big dehiscence, but sometimes he does it at the end, depending on each case.
So some cases, depending on the indication, some
Yes.
type of mucograft is
Yes.
also placed
Yes.
at the time of the decortication.
Not before or after, depending on each case.
Okay, thank you so much. That was a very intriguing presentation. Congratulations.
Thank you. Thank you.
Thank you so very much. Thank you.